I am here. I am ready. I am a couple minutes late. All right. Whew. And I realized I forgot my drink. Ah, hate it when that happens. All right, guys. Welcome to Cosi Talks Live. For those of you watching the replay, thank you again for your continued support. Feel free to put replay into the comment section. I like to go back and see who's watching the show after it closes down. And if you are watching the replay and you have a question for me, go ahead and feel free to put it into the comment section as well, and I will be sure to answer it. So I'm going to give you guys a couple of minutes to jump on board this evening. It is just you and me this evening, guys. It's just us chickens in the house tonight this evening in the Cosi Talk studio. I do have an amazing sponsored show coming up next week, but today it's just us and the general Q&A session. So guys, as you jump on board, don't be shy. Let me know who you are, where you're from, and what's in your mug, since I don't have mine with me tonight. I need a drink just to enjoy this show a little bit. But go ahead and feel free to start putting your questions into the comments section. Tonight is a free question and answer session, so don't be shy. And again, if you are watching the replay and you have a question for me, put it into the comments section. Hey, Felicia, how are you doing, darling? So good to see you. I'm so glad that I can picture your face now when I see your YouTube handle, because we got to meet at the Amputee Coalition National Conference. So it's always nice now that I know who you are. Hey there, Eric, drinking your Mountain Dew, watching me from the YouTube channel. So guys, just as a reminder, I am broadcasting from my YouTube channel as well. Sometimes it's a little easier for folks to find me there. We've got Scott in the house, cold water as always. We got Pastor David, it's a party with his lemonade. Scott, how's it going with that check socket, man? Have you been putting them through the ringer now again at your prosthetist office? All right, guys. So we got Marianne. Marianne, I haven't heard from you in a while, Marianne. I miss getting your emails. She says, I'm here with water and the Snickers bar, and I need glute exercises. I love that. Water, Snickers, and I need glute exercises. I love it, Marianne. Marianne, you have my program, so there's a lot of glute exercises in there for you. Start off with the basics with the glute bridges, okay? Let's get you started on those glute bridges, and make sure you watch the video on how I explain to do it. We got Emily here from Central PA. She's got her Barks root beer, hopefully going to inpatient rehab by Monday or Tuesday. Yes, and you're going to get your intensive rehab there, Emily. I'm so glad for you. All right, guys, we're going to give you another 30 seconds to jump on board. So guys, like I mentioned, tonight is a general Q&A session. It is open season on the physical therapist. So start putting in your questions into the comment section. I have two questions that came in this week, and they kind of one segues into the other. But after that, I'm going to be left here with an empty screen. So y'all need to give me something to talk about. All right, Scott says, I got the final socket right before my surgery. So hopefully a couple more weeks and I can start therapy. Wonderful, Scott. Oh my gosh, that's wonderful. I know you've had quite the long road in front of you. All right, guys, so we're going to go ahead and get started for this evening. So for those of you who are joining me for the first time, welcome. My name is Cosi Belloso. I'm a physical therapist, amputee specialist here in Florida, and it's not so hot, sticky, and humid anymore. Look, guys, I'm wearing long sleeves. It's beautiful, gorgeous weather right now that we are enjoying in Florida. Compadre, oh man, so glad you could make it, man. So glad. It says, we got Drew here, says, building a new click socket. What is the name or link to the new click dial? I want my socket to have it. Yes. So thank you for that lovely segue, Drew. So what Drew's talking about is one of my favorite items on the show, which is the Click Medical Adjustable Socket. It's called the RevoFit system. And last week we spoke about the Revo Surface. Okay. So just to give you the quick recap. So with the RevoFit, your prosthetist can build adjustability into the socket, and it's done by using this nifty little click reel. Now, the previous model had a BOA dial, and those are still absolutely wonderful. I know many of you have that, but they came out with the click reel, and as you can see, it's right there. It's a little bit more lower profile, so just a little, it kind of blends in just a little bit more, and it can adjust in two ways. So it can tighten, and then it can also loosen, and it's called micro adjustments. So with the BOA dial, you could tighten it, but then to loosen it, you would have to release all the tension all at once. So this is kind of a nice improvement that they've made. So it's called the Click Reel, Drew. And what you want to do, you know what, let me just type it in. I have typed in this website so many times that I have it memorized at this point. Okay, so it's www.clickmedical.co, okay, for Colorado. So that's where you want to go, and you're going to find all the information there. So, guys, if you have a new socket, you would be using the Revo Fit, okay? If you have a current socket, like you have your current existing socket, and now you want to put the adjustability into it, you would use what's called the Revo Surface. So it gives you the same adjustability. It's just a different way that your prosthetist would build the adjustability into it. Does that make sense? So guys, last week, if you want to learn more, go to last week's show. I had two amazing prosthetists, Billy and Ahmad, on loan to me from Kenny Orthopedics. There are, I think they said 27 clinics, something insane, in Kentucky, Indiana, and I think in the Carolinas. Two wonderful prosthetists that came on board to talk about how they use the Revo Fit and the Revo Surface on their patients. So if you kind of want some more details on that, go back to last week's show, and I would encourage you to find it on my YouTube channel. It's a little bit easier, and I'm going to just type that in there. It's funny, when I don't have a sponsored talk, I feel like my hands are just completely free. I have so much more time. Okay, here we go. Hey, comadre, happy Wednesday to you, mama. Emily asks, sorry, guys, let me make sure I get this. I don't want to miss any questions tonight. We got Rob coming in from Indiana with his Coke Zero. We got Chuck. Look, I'm so glad you're here, Chuck. So Emily asks, I know amputees deal with issues with heat and sweating. Are we more sensitive to temperature changes in general? It's starting to get cooler, and I feel like I get colder quicker than before. That's a really excellent observation, Emily, and it is not in your imagination. A lot of times people will ask me, I'm not sure if I'm imagining this. And I'm like, no, you're not. Okay, so what happens when you lose your limb, whether it's an upper extremity, a lower extremity? You lose surface area, okay? You're losing surface area of your skin, which means, okay, less space for you to sweat from, okay? So the number one job of our skin is to protect our internal organs and to do temperature regulation, right? That's one of the biggest jobs of our skin. Okay. And when I worked in the trauma burn unit many moons ago, I really, really came to appreciate just how much temperature regulation our skin does, right? So when we would have these poor souls come into the trauma unit with severe third-degree burns all over their body, right? They didn't have skin covering, right? And they were always really cold, really, really cold. The burn units were actually kept a little bit on the warm side because of this, right? So heat was escaping from their bodies. And on top of that, they were expending a lot of calories trying to kind of keep their metabolism, trying to keep their body temperature up. So on top of being cold all the time, they were constantly having to eat like 2,000, 3,000 calories a day to make sure that they weren't losing too much weight, right? So skin, really, really important, right? With spinal cord injury patients, right? Depending on the kind of spinal cord injury they have, they may not sweat below the level of their injury. Okay, so stop and think about that for a second. Let's think about Christopher Reeves, right? How many of you guys remember Christopher Reeves? He was not the OG Superman, but he was my OG Superman, right? From the 1970s and 80s, right? So Christopher Reeve had that accident where he became a C4 quadriplegic, and he was paralyzed from the neck down. And he was a complete quadriplegic, meaning he had nothing, no movement, complete paralysis. So in his case, he was not able to really regulate his temperature normally below the level of his injury, right? So for someone with a spinal cord injury like that, that can be life-threatening, right? If you're not able to regulate your temperature, if you're not able to sweat normally, because that's the other purpose of sweat, it's to get rid of toxins in our body and to help regulate temperature, right? Our skin does a lot of work, and we really don't give it enough credit, right? So when it comes to amputation, it's not quite as dramatic or as life-threatening. Obviously, it's not life-threatening like it is for someone with a spinal cord injury or someone with a burn injury. But with amputation, you're losing a big chunk of surface area from which you would have normally sweat from, right? It's not there anymore, okay? And your body still has to regulate its temperature. So it means that you're going to sweat more from the skin and surface area that is left. Now, I've heard a lot of things over the 23 years that I've been practicing as a physical therapist. I have some people who say that they notice that their residual limb that it sweats a lot more, and not just because they're wearing a prosthetic device that contributes to it. But even when they're not wearing a prosthetic device, they notice that their residual limb sweats more in comparison to the rest of their body. And it kind of takes them by surprise, right? In other cases, and I usually hear this more often, people say that that they sweat more profusely in general. Okay, so it seems like their entire body is kind of picking up the slack a little bit for that missing surface area of skin. Okay, so it's not in your imagination if you're noticing, wait a second, temperature regulation here feels a little off. Like I feel like I'm sweating more from certain areas. Now, for a lot of people, it kind of regulates over time for amputation, right? So they kind of, their body kind of establishes, gets a new homeostasis going and stuff like that. Other people, no. Other people still tend to have a lot of these issues. And sometimes even with my women, as they get into the perimenopausal and menopausal years and the hot flashes begin with everything else, right? Then they also start to experience that. So, talking to my patients a lot about sweat management, especially here in Florida, huge part of the conversation. Okay. Hey there, comadre. Happy hump day, Denise. So Marianne says that she prefers to have the old BOA compared to the click reel. Marianne, I'd love to hear your why behind that. Ryan asks, this is a good question, Ryan. He's an above the knee amputee, and he says, my limb does not hang down due to hip flexion after 2 years of stretching and lying on the stomach. It's still fairly offset in the socket. Have you heard of Botox possibly to release that muscle or anything? Stretching isn't working, and I'm diligent in trying daily. Any suggestions? So Ryan, that's a really, really great question. And this is something that Ryan, here's what I want you to do for me. I am typing down my email address. I want you to please email me your question, because there's some parts of it that I'm going to have to look up a little bit more on the research. Guys, and by the way, this is for everybody, especially those of you who are new to watching the show. I forgot to put that in my introduction. This show is for you. This show is for the amputee community, and that includes my amputees, my clinicians, and those of you who are family members and caregivers of amputees. So this show is for you. It's meant to answer your questions, whatever they may be. I may not always have the answer, but I will go and I will find a good, credible answer for you. So, Ryan, your homework assignment is I want you to email me your question so that I remember tomorrow to look up the part of the answer that I need to look up. But what I can answer for you, and we can talk a little bit about hip flexion contracture. So that's exactly what Ryan is referring to, hip flexion contracture. And we cover that a lot on this show. Okay, so quick anatomy lesson. You have a big old fat juicy muscle here, and it's called the iliopsoas. It's actually two muscles, the ilius and the psoas muscle, but we call them iliopsoas because they kind of just blend in together. And it starts here on the inner part of your iliac crest, that pelvic bone right here, right? And it comes down and it attaches right around here. So it's a very big, thick, wide muscle, but it's not very long. Okay. So it's the laws of mechanics, basic, simple laws of mechanics. When you have an amputation in your femur, especially, right, this big muscle is still intact. And it doesn't have any counterweight. It doesn't have the weight of your leg to kind of weigh it down and keep it in check. So what happens is that muscle gets tight and your hip starts to stay in this position. And it might develop into what we call a contracture, meaning really, really, really tight and unable to stretch it out. And this can present with a whole host of problems when it comes to using a prosthetic device, okay? Number one is that you're not able to extend your hip. And you should be able to, depending on the textbook you read, you want to be able to extend your hip at least 30 degrees back, right? To get the full advantage of walking and to have a really nice, efficient gait pattern, right? So if your leg is stuck all the way out here, wait, I'm turning Bob around. If your leg is stuck here and you can't move it past, right, you're limiting a lot of movement, and it's going to travel up your spine, and it's going to cause a lot of problems with your gait pattern. So what's a person to do? Okay, stretching, right? This is where your neighborhood-friendly physical therapist really can shine, right? This is something that we start to address. I know I start to address with my patients from day one after surgery, right? Their eyes are opening up after surgery, and I'm going, hey there, we need to start stretching you out, or at the very least start positioning your residual limb to make sure it does not get a contracture. Okay, so some of you might remember from those early groggy days after surgery that your nurses and your physical therapists and your occupational therapists were positioning your residual limb in a way so that it wouldn't be lifted up, right? That they would position it down and flat so as to flatten this front part out, okay? And then as you got better, as you started to improve and receive more PT/OT, you were probably taught, hopefully, stretching exercises where you may have been laying on your belly. You may have been laying on your back with your leg hanging down. And Ryan, in just a moment, I'll show you one of my exercises that I like to give my patients for this particular thing. Now, does this always work? No, because when it comes to stretching, you have to be on it like white on rice. And unfortunately, even sometimes my most diligent patients will start to develop a contracture. I mean, you're dealing with a really, really big muscle there, right? And then the shorter your limb, the stronger of the pull of that muscle. And by the way, guys, I always say this, my below the knee amputees, you don't get off the hook, right? Just because you have a longer limb doesn't mean you're not going to be prone to hip flexion contractures, okay? So Ryan, a couple of things. If it's been a couple of years, then chances are, yeah, you might have a fixed contracture, okay? And there's a couple of ways to deal with a fixed contracture. One of them is surgery. And again, that's usually a last resort because it's a pretty intense surgery to go in and release the muscle, to surgically release that muscle, right? When it comes to Botox, yes, there are a lot of uses with Botox to help relax a muscle. I would see it back when I was when I was working in the pediatric population and we had children with cerebral palsy and they would have a lot of tone, a lot of spasticity in their muscle. They would get Botox injections to help relax that muscle and to allow us to stretch the muscle. This is the part that I have to look up, Ryan. I need to look up in the research and literature to see if in a fixed contracture, you can use Botox and have it become effective. I think the answer is no. But again, I'm going to go back and check the literature. And this is where I need you to please send me an email to remind me to do this. And here's why. When you have a fixed contracture, it means that those muscle fibers have actively shortened and they are fixed and shortened in that position. Okay, so relaxing that muscle is not necessarily going to pull those muscle fibers apart. It just means they're going to be relaxed, but they're still in that shortened position. Does that make sense? But again, gonna look this one up. I know I say that a lot, but I want people to understand that sometimes you got to check the literature. That being said, guys, I'm going to go ahead and share with you. It's been a while. I have my strong body program. Ta-da. So Ryan, if you'll bear with me, I'm going to show you one of the exercises that I really like to use with my patients. Again, you can try it out. It may or may not work, but it's something that you can try out for stretching. And let me go ahead and share the screen. Okay, here we go. All right. So we're going to go to my above the knee. We're going to go down to, so some of you who have my program already, if you want to find this exercise, if you're in above the knee, obviously you go under above the knee to flexibility. If you're in below the knee, again, it's also under the flexibility because this particular exercise can be done both by above the knee and below the knee. So here's the one for hip flexor stretch prone. Ryan, this is not something I would necessarily recommend for you for having such a tight contracture, just because I think that you'd be stretching out your lower back and you wouldn't be able to target the iliopsoas muscle. So the one I would want for you to try is this one. Hopefully the sound will go through. So probably the number one culprit when it comes to being tight in a particular area for an amputee is the hip flexor area. That's the front part of your hip. You've got a lot of big, strong muscles here that help move your residual limb up and down, and they can get particularly tight. So there's two ways of stretching out this hip flexor muscle that I like to use. With this one, you can do this on your bed, and I'm going to have Robin scoot to the edge of the bed so that the residual limb is hanging off the edge. So you got to scoot over just a little bit more, and just be careful with this one, folks, okay? Now for this one, all you're going to do is you're going to let gravity take effect. So she's going to allow her residual limb to hang off the side of the bed. And as you can see, she does have a little bit of tightness. But this is a really great way just to kind of slowly let this stretch down and out. Sometimes folks like to keep their prosthesis on while they're doing this exercise because of the weight of the prosthesis can help bring down this particular side of the hip. You can also bring this knee up and bend your foot up just to take the stress off your back and also help with the balance. So with the stretching, I just recommend starting with 10 seconds, letting it hang for 10 seconds, and then bringing it back up onto the bed just to rest, and then bringing it back down. If your lower back is hurting during this exercise, you can put a little towel roll under your back, or you can also just adjust your foot to take the pressure off your back. Give it a try. Is my audio back? I'm just gonna wait for a moment for you guys. Can you guys give me the thumbs up that my audio is good? Is my audio back, guys? Yes, thank you. Okay, thank you, David. Okay, so Ryan, hopefully you got that. I'm like scrolling through these comments to try to like make sure I get everything. So if you have my book, guys, okay, this is the below the knee book right here. If you have my book, it's in the flexibility section. So it's in the back and it's called Hip Flexor Stretch Supine, right? So this is the one with below the knee. It's done pretty much the same way. Guys, if you haven't looked at these videos or these books, yes, I'm plugging it because it is part of my program and all that kind of good stuff. It's a really great program, okay? So those of you who need exercises, those of you who need stretches, those of you who want to give this to your physical therapist who maybe don't have experience working with amputees, there's the book and there's 150 exercise videos like the ones that you just saw for above the knee and below the knee amputees. Okay, I won't plug that anymore. Okay, so guys, when it comes to that particular stretch, and here's the thing, when it comes to stretching, and this is not just for the iliopsoas muscle, this is for any muscle in your body, it's the Goldilocks scenario, right? Too little, you're not stretching. Too much, you're going to hurt yourself. Okay. You need it to be just right. Ryan, for someone like yourself, especially if you've had 2 years and we are suspecting worst case scenario, and I always like to give you worst case scenario, that it is a fixed contracture, you cannot be aggressive with the stretching. Okay. The reason is if it's like completely fixed and you're pulling and jerking on it, this part's not going to be what moves. It's going to move the other parts of your body that it's attached to. Okay. So since it's attached to the hip, it can start to bring your lower back into the equation and pull your lower back. And we don't want to do that. So again, Ryan, this is something where I would really recommend talk to your physical therapist, have them really examine what is going on there to see if it's a fixed contracture or if there's still pliability in that contracture, okay? And then yes, talk to a surgeon. I would say the person you would want to talk to would be a neurosurgeon or a neurologist to see if a Botox injection would be applicable for you, because they would be the ones who have the experience of injecting muscles that are high in tone, spasticity, or contractures. Yeah? Okay, that was a really great question. Really good question. Okay. Scroll. Emily says, is there a reason a pin lock doesn't always click in right away? Mine usually does, but I have got to stand to get it to click in place. Oh my gosh, yes. Emily, no joke. I was probably doing this show for about a year, right? And I have a lovely network of physical therapists on Facebook and Instagram, and some of them started kind of getting wind of the fact that there was an amputee specialist out there that was doing a show, right? So I had a physical therapist who reached out to me. His name is Jeremy. He's an amazing physical therapist and just a good person, right? But he doesn't necessarily have experience working with amputees. He's mainly a neck and back physical therapist. He's awesome at what he does, right? But he had an amputee come in and he wanted to help this amputee. And he said, Cosi, I spent 2 hours trying to get that pin lock to lock into that little tiny hole. And he could not make it work. Guys, I have a love-hate relationship sometimes with pin locks. They're sometimes the greatest things ever. You just click in, pop it on, and off you go. Your patient feels nice and safe and secure, and woohoo, everything is great. And then other times, oh dear heavens, to get that little pin into that little hole and to get it to click, the amount of times it has to go, right? And I know some of y'all are going, yeah, yeah, been there, done that, gotten the t-shirt. So a few reasons why you might be struggling, Emily, and in your case, because I do know you have, you've let us know about your history with lymphedema. It's usually because the limb is swollen, right? So if the limb is swollen and you're trying to kind of shove it into the bottom, and maybe it's a shorter pin, it could be that the pin is not getting all the way down to the bottom, so you're not going to hear those clicks. The other thing that is a very common thing to happen is if the liner is not put on properly. Oh my gosh, this is such a pain, right? If the liner is not put on by like a few millimeters, right, then your target is completely off. You're not going to get that pin into that hole. Or if you do, you're going to feel like you're pitched forward because the angle is completely different with your residual limb. And then you have to basically take the whole thing off and start all over again, right? And guys, I know I sound like I'm being a little bit dramatic with it when these pin locks. And I've got a few prosthetists here on board, and I'm thinking they might be maybe nodding with me in agreement, or maybe they just think I'm nuts. I don't know. But when it comes to the pin lock, usually it has to do with the fact that your limb is swollen, okay? And you have to kind of manage that. So Emily, for you, it means really following your protocols with lymphedema, especially at nighttime, whether you wear a wrap or a special compression stocking, that you're diligent about doing that. It could be that you have to kind of get up in the morning and just kind of move around a little bit in that leg until you can finally kind of bounce yourself and get yourself into it. Again, this is where I think an adjustable device is absolutely wonderful. And yes, you can use a pin lock with the Click Medical. So the pin lock is your suspension system. And yes, you can have that placed into the socket with a Click Medical adjustability in there. So having that kind of adjustability, and I've noticed that prosthetists tend to want to use the hinge design when they have someone who has a slightly more swollen limb. And then that way you can slip in a lot easier in those morning hours. Okay, then Gregory. Oh, so glad to see you, Grasshopper. We got Harsh on board from Richmond, Virginia. Harsh, I am coming to see you. Okay, so guys, I'm going to take a quick moment here. So y'all have heard me talk about in the past about the Mission Gate organization. It was founded by one of my colleagues, David Lawrence, who's an amazing, amazing physical therapist. This guy is just crazy amazing. And he created this organization to be an educational resource for physical therapists. So one of the big things that they do is the Discover Your Possible event. And I'm going to go ahead and put that up. And guys, just keep an eye on my social media, because I will be putting up some promos for that very shortly. So it's Discover Your Possible by Mission Gate. And it's this wonderful in-person event. It's going to be the third year now that they do this, and it's for amputees. It's for amputees. So I am very honored to once again be the keynote speaker for that event. So I will be speaking all morning. So Harsh, that's where I met Harsh the first time, and hopefully I'll be able to get to see him again. It'll be on November 4th or 5th. Don't kill me, Robin. I know what date it's supposed to be. I know I have my plane ticket ready to go. So guys, keep your eyes on my social media for this event. Those of you who are anywhere near Richmond, Virginia, this is something you definitely would want to come to. And then in the afternoon, so I'm talking in the morning, yeah, no big deal. But in the afternoon, that's where the real fun's going to begin, because they have all sorts of adaptive sports and fitness groups and organizations and people coming in and bringing in all the toys. And it's so much fun. So much fun. Okay. Okay. You guys got a lot of great questions, and I want to make sure I don't miss anything. Okay. So Marianne says, Emily, it sounds like you're going in a tiny bit crooked. Yes. So referring to the pin lock, that is also a possibility. Mark, it's halftime, no Facebook notification. Mark, are you signed up for my texting services? Guys, how many of you, can I get a quick show of hands? How many of you are signed up for my texting service? And yes, I know this is another shameless plug, but there's so many of you who are telling me that you are not able to find me because Facebook does not give you notifications. Shame on you, Facebook. So guys, I don't spam you with my phone messages or anything. I just send one message 15 minutes before I go live, and I put the links down there so that you guys can just find me easily and not have to wait for Facebook to notify you. Okay. All right. Next. All right, Denise, what about the smaller hip muscles? So yes, Susan, you've got a lot of big muscles and little muscles. So the big muscles in terms of the hip flexion, it's going to be the iliopsoas and maybe a little bit of the rectus femoris. That's part of your quadriceps muscle, just a little bit, not really a whole lot contributing to that. But it's mainly when it comes to the flexion, it's the iliopsoas. Those are the big ones right there. So you'll be targeting that. Okay, so when you're doing that particular stretch that I showed you there, Susan, you're going to hit that general area. Okay. Denise says, one of the reasons I went away from the pin lock initially, my limb size varied so much from day to day, and the slightest difference always made it difficult to click in. I always had to stand to get it to click unless it was late in the day and my limb was a little bit smaller. There you go. But only did that a handful of times. The pin lock offers security. Yep. To new amputees, and it was on and off and not going to fall off. So as I progressed with walking, I felt like I was dragging something behind me. Now I have suction with sleeve and it feels more connected to my body, and I can always get it on even if my limb size varies a bit. So the variations in size have definitely leveled off, but I'm a little over 5 years. So Denise, beautifully stated, beautifully stated. So Emily, same thing. I mean, you're still new to wearing a prosthetic device. The pin lock is, I think, a good option, especially for my beginners, for all the reasons that Denise, she just hit all the major points right there. It gives you that security. It is easy to put on if you have a good fit there. But yes, so this is something that as you start to wear your prosthesis more and more, you can decide whether this is the system you want to stay with, or perhaps in the future move on to a different form of suspension. Yeah, sometimes you do have to fight it a bit, true. I agree. Um, Susan says, I had a cortisone shot in my hip because of a trapped femoral nerve. It stopped the pain so far, and it's been 4 months. I was told it happened to some amputees that have broken their hip. Yep, could be. Um, Patricia asks, I'm a left above the knee amputee. When my prosthetic is off, I occasionally feel something moving in my residual limb. Is that the bone? It could be. So it just depends on the kind of surgery that you had done. And I do notice like my AKs feel a bit more sensitive to this, right? That sometimes they'll feel like almost like their bone sometimes is like snapping on the muscle. So it depends if the muscle is like going all the way around the edge of the bone like a muscle sling, right? And you're kind of bearing weight into it a little bit. It might feel like the bone is kind of jiggling around in there like that. So that's something as well. One thing of note, if you have any hardware in your limb, Patricia, if you had like a broken bone and they had to put a metal rod in, or any kind of screws, or for whatever reason, if you have any of that in your leg and you feel like there's something in there moving, you might want to give your doctor a call and just make sure it's not any hardware that's coming loose. But again, that's pretty rare, but just something that's the little asterisk to that answer right there. Oh, Kays is on board. Wonderful. Have I heard about the rosin socket, the rosin socket? I have not. Susan, can you please email me that one? So I've got 2 more homework assignments. So Susan, email me about the rosin socket and what specifically do you want to know about it? Okay. All right, Harsh, I'm glad to see that. All right. Doug is asking, do you know anything about the Martin Bionic socketless socket? So yes and no. Do I know it exists? Yes. And I've had a couple of patients with the Martin Bionic socketless socket. So that's kind of their tagline for theirs. And it's basically it's a version of an adjustable socket. So guys, always on the show, and I say this about prosthetic feet, knees, sockets, surgeries, whatever you have. What I present to you on the show is a snapshot, right? It's a snapshot of what is available to you out there on the market, right? And I do have sponsors that come on the show to present to you what some of those options are. Usually when I choose the sponsors that I work with, it's because I hear a lot from you all, your interest in wanting to hear about a particular product or surgery or whatever. And also because I kind of keep my ear out and I listen to what people are using and what they are enjoying to use. So when it comes to adjustable socket technology, there are a couple of different options out there on the market. One of them is obviously the one that you hear me talk about the most is the Click Medical RevoFit adjustable system. You also have the Martin Bionics socketless socket. And then you have one called Limb Innovations, which they were on my show many years ago. Haven't seen them around too much. I still occasionally see someone walking around with one of those, but don't know much about what's going on there. When it comes to Martin Bionics, I have not worked directly with that company. Okay, so I cannot comment on those sockets as much as I can comment on these sockets because I just know and I have more experience working with this particular adjustable socket system. I do know with the Martin Bionics socket, from my understanding, you need to go to a clinic that specializes in the Martin Bionics. And I think, and again, guys, this is just from what I'm hearing in the community. We have one here, for example, in Tampa. So there's a clinic here that is owned by Martin Bionics, and the prosthetist, that's the kind of socket that they specialize in making. So like I said, I've had a couple of patients with the Martin Bionics socketless socket, and they like the socket. So my recommendation to you is if you're looking for adjustable socket technology, take the information that we've given you here on the show, go look up stuff on Martin Bionics and take this information to your prosthetist, right? There's no one fit for everyone. And this includes the Click Medical socket, right? This is not going to work for every single amputee, right? Everybody's unique and different. And every prosthetist has their way of doing things. I have seen some prosthetists that they make their own version of an adjustable socket, and it looks great and it works wonderfully for their patients. The one guy up, I use him as an example all the time, Bremer Prosthetics up in Northern Florida, I think his name is Rick, as the prosthetist there. He makes his own version of the adjustable socket and looks fantastic. Okay, so it's something that you need to talk to your prosthetist. You need to ask specifically or let your prosthetist know, this is what I want an adjustable socket to be able to do for me. And then start that conversation to see if it's going to be right for you or not. Yes? Okay, so Emily got the text. Scott got the text. Ryan, yes, we got, okay. Rob says, I signed up, but I haven't been getting notifications. Rob, can you please email me? And that way I can, whoops, daisies. I called up a whole different screen. I wasn't meaning to do that. All right. So once again, that is my email address right there. Oh, Harsh, thank you for putting that up there. I'm like, what is that complicated looking link? Okay. So Harsh just put up the link for the Mission Gate Discover Your Possible event that I will be speaking at in November. So for those of you who are in the Richmond, Virginia or anywhere near that area, that's the link to click on. So thank you, Harsh. Thank you, Susan, for doing that. Ben Gregory's been getting my text. Denise's been getting my text. Awesome, guys. My pleasure, Doug. Okay. Okay, so guys, I actually put a teaser up in the title this evening about, what happened to my patient who decided to, what happened to my patient when he was prescribed too many medications, okay? So this is a little bit of a long story, but just bear with me on this one. It came about because a person was asking me about what does it mean when a physical therapist is a direct access clinician, okay? So many moons ago, dinosaurs walking the earth, I'm going to school. Literally a couple of years before I applied to physical therapy school, you could practice as a physical therapist with a bachelor's degree. Okay. And prior to that, it was a certificate type profession. So this was back in the 60s and 70s, I think, right? So by the time I started school and applying to physical therapy school, everything changed nationwide, and it changed from a bachelor's degree into a master's degree. So the bachelor's degree in physical therapy no longer existed. You had to have a master's in physical therapy to practice and to apply for a license to practice. And the reason is they did an overhaul on the physical therapy curriculum. Okay. And it was to add more education on the medical side of treating patients. That's kind of the gist of it, right? So we had courses on pharmacology. We had more courses on differential diagnosis. We had courses on radiology. Okay. And the reason is because we were seeing that physical therapists were becoming direct access clinicians. So what does that mean exactly? So what it means is, as a physical therapist, okay, licensed in the state of Florida, every state's slightly different with their laws, a patient can come to see me without having a prescription from a doctor. Okay. So oftentimes, many of you will get a script, right? And it'll say from your doctor, physical therapy, evaluate and treat 3 times a week for 6 weeks, right? And you take your little prescription to the physical therapist and off you go, right? Well, what direct access means is I don't need that prescription, right? And there's very strict laws about it here in Florida. It says basically like I can see a patient for the first 30 days without a prescription, after which I then have to obtain a doctor's prescription if I continue to follow that patient. Okay. So, what does that mean? Like, why does that matter? Okay. So, oftentimes, what that means is that I have to evaluate the patient very, very carefully and very differently from another clinician who does not have direct access. So, an example of this is our prosthetists. Our prosthetists are not direct access clinicians, right? You must have a script to go see a prosthetist, right? They have to have a prescription so that the prosthetist can make the socket for you. Okay. So what does that mean? When a patient comes to see me, I do a head to toe evaluation. And oftentimes my evaluation is going to look very similar, not exactly, but very similar to the evaluation you might get from your primary care doctor when they come in for a checkup, when you go in for a checkup. Okay. And the reason for this is when people come to see a physical therapist, whether it's about back pain, balance issues, shoulder pain, right? As a physical therapist, we need to be able to differentiate between what is an orthopedic issue and what is not. Okay. That's what the direct access really truly means, especially for me as a clinician. Okay. So if I have a patient who comes in, right, and they're presenting with back pain and I'm doing the examination and I'm going, I don't think this back pain is related to the lumbar vertebrae. I don't think there's anything from the muscular skeletal system that is causing this back pain. I think this back pain has something to do with the patient's kidneys. Okay. So, as a direct access clinician, it is then my responsibility to refer the patient back to the doctor to get further workup. Okay. So, that's just one example of things that can happen when you're seeing a physical therapist as a direct access clinician. Okay. So one of my favorite examples is issues with pharmacology. Okay. And again, this is where the training of the physical therapist is really sometimes underestimated, in my opinion. Guys, I'm going to get a drink of water because my throat is about ready to give out on me. Give me 1 second. That's how you know you've been talking too much and your throat's giving out on you. Okay. So another one of the examples where the training that a physical therapist receives helps in situations like this is when it comes to pharmacology. And this is a topic that I've covered briefly on the show. And I actually did a really big show on it about 2 years ago. I probably need to do an updated show, right? So it has to do with pharmacology. So one of the things that a physical therapist will do is that they will review the medications that you're on. Okay. Couple of reasons. Number one, we need to know just the medications that you're on because that's just basic knowledge of a patient. We need to know what are the side effects that you might be experiencing from this medication and also any potential interactions that may be going on. Okay, so one of my most kind of infamous cases when it comes to pharmacology and catching some of these issues that happen, okay, is a patient I had. It's been 8 years now. So this was before my cancer diagnosis. I was working home health and I went to go see this particular patient. And in this case, I did have a prescription from the doctor and it said, treat patient for balance, beginning stages of Alzheimer's dementia. And the patient had been falling down a lot. He lived on a farm setting, a lot of rough terrain, very, very tall man. He was probably about 6'1", and he had been falling a lot using his walker. I said, okay, sounds like a pretty standard case for balance training. Well, let's go work with him. So I'm speaking with him and his wife, right? And she said, yes, he just received the diagnosis of Alzheimer's dementia. And I said, And she said, yes, it's beginning stages. And I go, because a lot of his symptoms and a lot of what they were reporting and what I was seeing, I'm like, there's a lot going on here for this to be the beginning stages of Alzheimer's dementia. And guys, I'm not an Alzheimer's expert. I have colleagues who run circles around me with that, But I've worked enough with Alzheimer's patients to know like a beginning diagnosis or somebody who's in the beginning stages does not look this severe, right? This man was struggling to get from one end of his house to the other with a walker. And it was interesting because the wife had reported to me that even just 6 months prior, he was fine walking around without any kind of medical device. So as I was working with him a little bit more, okay, I also started noticing that his heart rate was all over the place and so was his blood pressure. Okay. So we called the doctor, sent him back in. Doctor said, no, he's fine. I said, he's on a lot of medications, especially for blood pressure. We sure he's okay? No, he's fine. And this was the cardiologist. So I worked with him a little bit more and he wasn't improving, guys. And that for a physical therapist is a red flag. When we are working with a patient with balance training and the patient is being diligent about doing their exercises and their program, you expect to see some form of improvement, even if they have an Alzheimer's dementia. If it's in the beginning stages, you can see, right, a difference. No difference. Blood pressure, heart rate still all over the place. So I kept sending him back to the cardiologist, sending him back, sending him back. Cardiologist kept sending him back home saying there's nothing wrong with this guy. Finally, one day, and I'm calling my director of nursing, which by the way, in home health, I answer to a nurse practitioner, right? And she keeps saying, Cosi, we can't discharge this guy because obviously there is something wrong with this guy and we got to just keep sending him back to that doctor until that doctor pays attention to him. And in this case, he had a doctor cardiologist who was a cardiologist in the civilian world, but he was also being prescribed medications by another doctor in the VA system. Okay. I go back one day and he's looking at me and he's like, I'm not feeling really great. And he had his face, it was, guys, it was the same white color as this background. And I take his heart rate and it's in the 30s, right? So I call 911. I said, well, I got a patient here who looks like he's about ready to go into cardiac arrest. So I need y'all to get over here real quick. And they did. They got over there very quickly. They took him off to the ER. Lo and behold, his cardiologist decides to show up and says, oh my gosh, you're on a lot of medications. So they take him off 5, guys, 5 blood pressure medications, 5. And all of his balance problems disappeared. So guys, I know this is like a really long-winded discussion on things that can happen, things that can happen, things that can happen. Okay. When you go see your physical therapist, when you go see your clinicians, right? I talk a lot about being an advocate for yourself. And this is one of those things that is incredibly important when it comes to your medications right there. Okay. In the case of this particular patient, he had been prescribed 5 different blood pressure medications by 2 different doctors, right? And those 2 doctors were not speaking to one another, right? Because they were in completely different hospital systems. So for me, it is your responsibility as a patient to make sure that when you go see your different clinicians, whether it's the physical therapist, whether it's the doctor, whether it's a surgeon, that you are bringing your own complete list of medications, right? And making sure it's presented there. So I know that was like a really long-winded point, but I just wanted to kind of make that point this evening. Ooh, Van Gregory. Really great question. So Van Gregory is asking, what are a couple of major minor differences and requirements between being a physical therapist and a personal trainer? The biggest difference is a physical therapist is a clinician. A personal trainer is not. That's it. So a physical therapist nowadays, now they have to, so I talked a little bit about how a physical therapist used to have a bachelor's degree. Then in my day, they were required to have a master's degree. Now they're required to have what's called a DPT, a doctoral in physical therapy. So the level of education has increased to that. And those of us with the master's and the bachelor's degrees, we have been grandfathered in. So meaning even though my initials behind my name say MSPT, Master's in Physical Therapy, I have the same ability to practice, the same scope of practice as someone who has a doctor in physical therapy. My curriculum is matched and grandfathered in. Okay, so the physical therapist is exactly that, is a clinician. And kind of what I just spoke about now about all the different training that we have in assessing, evaluating, diagnosing, and treating disorders of the musculoskeletal system. That is what a physical therapist does. A personal trainer, okay, simply put, is they know how to strengthen muscles. That's it. They're involved. They are experts in fitness. And depending on the personal trainer will determine how much education that they've had. I've seen some folks that in 3 days, they take an online course and then all of a sudden they're certified to be personal trainers. And then you have other personal trainers that get more training and more in-depth training. They are not clinicians. And this is something that I cannot stress that importance enough. Okay. And I've worked with personal trainers in the past. I have nothing against personal trainers. I actually really like it when my patients will transition to working with a personal trainer after they've worked with me. But what I really insist upon is having a conversation with that personal trainer and letting them know, hey, please understand that this is a liability that you need to accept in working with an amputee patient that may have medical conditions, right? These are things that you need to be aware of as a personal trainer. And these are things that you need to understand to refer back to me if this starts happening during treatment, right? Oh my gosh, my throat. That's how I know I've been talking too much, right? So that by and far is probably one of the biggest differences right there. Okay. And yes, I won't lie, guys. It is a huge pet peeve of mine. And I try to be nice, but guys, it's a huge pet peeve of mine when I hear someone say, oh, my personal trainer told me that I have this wrong with me or that wrong with me, or I have a bursitis, or I have a tear in my meniscus. And I'm just sitting there going, your personal trainer has no business diagnosing that. None. None. That is above their pay grade and beyond the scope of their practice. Okay? And that's my little pet peeve right there. And I'm going to let that one go right there. It drove me up the wall with that particular patient. And it was just one of those things where it happens a lot. And it's one of those things, it was during that particular patient, and I've had very other cases in those flavors where having that direct access and having the training that allows me to have direct access helps us spot these errors that can happen in our healthcare systems. And guys, I've had colleagues of mine that have caught some really big whoppers of mistakes. But again, that's part of our clinical training. That's what we are supposed to be doing. We are supposed to be evaluating and going through everything to make sure to see if there's anything going on, whether from the pharmacology standpoint or something else. Emily says, I'm surprised the doctors didn't ask the patient about their meds. My doctors always do. Yes. And here's the thing that's interesting, Emily. And I think back to my own examples, my own personal examples. So I have a primary care doctor. I have an OBGYN. I have an oncologist to follow me for my breast cancer. And I have a breast surgeon to follow me from the breast cancer side of things, right? So that's 4 clinicians. And then in my case, I have a nutritionist that I work with who's a functional nutritionist. She is a physical therapist who practices functional nutrition. So I have 5 different clinicians that I see at some point or another, right? 3 of them are in the same hospital care system. So theoretically, they should have access to all of my records and have a complete records. Doesn't happen, guys. Doesn't happen. All right. I'll go see my oncologist for my visit there, and I'll tell them, just look in the system and all the medications should have been updated. They're not. But my oncologist is good about asking me. And I know this is just something that I've accepted, guys. Our healthcare system, not perfect. It's not. It's not perfect. Okay. So even for myself, I have to make sure I have a list of whatever medications I'm on, whatever vitamins I'm on, whatever is going on in my life. And I have the same list with me when I go see my primary, when I go see my OBGYN, when I go see my oncologist. And I don't assume that records were transferred properly. I always make sure that the tech, usually it's the tech doing the intake to see what medications are on. And I make sure that I'm looking to see everything. Okay. It is what it is. Okay. That's just the way our healthcare system is. Now, what happens a lot of times, and this is what I would see a lot in my home health population, we have a huge VA hospital here, good veterans hospital, good doctors, right? But their patients are seeing doctors in the VA hospital, and then they're seeing patients in the civilian hospitals and the civilian clinic care systems. So those 2 systems do not exchange records. They don't have access unless the patient gives access to those records and unless the patient is doing this themselves. So there's a potential for a lot of medical errors in that. Okie dokie, let's see. Doug says, my wife was grandfathered in with a bachelor's in OT. Yeah, and we're seeing the same thing with the occupational therapist. And again, the big transition from bachelor's to master's was to allow physical therapists to have that primary access. Now, do physical therapists take advantage of that primary access? Not necessarily. And this is sometimes just because of the nature of where they might work. So whenever I worked in a hospital or in a clinic or in home health, I was required to get a prescription from the doctor before seeing a patient. And that was just the policy of the hospital or the clinic or the home health. In my own private practice, I will see patients using my direct access rights, privileges that I have as a physical therapist. And then usually if I see them for longer than those 30 days, I'll send them back to get the prescription from the doctor and we just keep going about our business. So. Okay, so Susan says, all my meds are in files that all hospitals, doctors, surgeons can call me up in the computer and all my files are there, including up-to-date meds. And again, that usually is the case. Like of the three, three out of the five clinicians that follow me for my health, 3 of them are in the same hospital system. But even then, I'll find discrepancies in my records all the time, guys. Let's see. Yes. Again, for me, it was always the medications that as a physical therapist, when I would go to home health, especially in home health, oh my gosh, patient would get discharged from the hospital. They would send me a medication list and it was completely different at times from what my patient was taking. And guys, when my father was in the hospital multiple times, he would be admitted to the same hospital, right? One time he was admitted 4 times in 6 weeks to the same hospital, my poor father. And it would just blow my mind how his medications would be completely all over the place, even though we had been to that same hospital over and over and over again. And as his advocate and as his caregiver, I had to constantly be on the nurses and sometimes even day to day. I would talk to the new nurse on the morning shift and say, hey, can we please review the medications? Because I think you're trying to give him something that they discharged from his records yesterday. And I would catch that a lot. So, it's just one of those things you got to stay on top of it. Scott says, my pharmacy gives me just every month along with pages showing why taking them and when, as well as pictures. It's great. Yes. And guys, patients are the ones that you don't have to be a pharmacist. And I did a show on this and I probably need to update the show because it's been, I think, 2 to 3 years since I did the show on pharmacology. You don't have to be a pharmacist to be able to manage your medications. And guys, for me, in all of the realms of physical therapy, all the things that we know, pharmacology is my least favorite. There's a reason I didn't become a pharmacist, and it's just because that part just doesn't interest me. It's something I have to do for my profession and for my patients, but I'll have to say it's my least favorite part of it. But guys, the main thing to know when it comes to the medications is knowing the name of the medication, knowing the generic name. You have your trade name and then knowing the generic name, okay? Like understanding that Tylenol is the trade name, acetaminophen is the actual name of the chemical compound of the medication you're taking. Knowing what dose that you're taking, knowing the side effects, knowing obviously how many times and how much you're supposed to take, and then knowing if or when you are supposed to stop taking the medication. That was a big one I would catch with my patients. I would see my patients that they would be taking their antibiotics for a really long time, not understanding that they had to stop taking the antibiotic, and the doctor didn't necessarily tell them that. So when it comes to these medications, it's asking these questions like, obviously, how much am I supposed to take? Is there ever going to be a stopping point to taking this medication? When should I have this medication reevaluated? Okay, because there are some medications that you can be on them for a few months, but after that, they have to kind of take you off, right? And what are some of the side effects that I should be expecting? What are some of the side effects I should not have? And that's a big one. What are some of the side effects? And I've asked this of my doctors, especially when I was going through breast cancer and everything like that. And I would ask my doctors, what side effect should I know about that if I get this side effect, I need to give you a call right away because it means something is being toxic in the medication. Woo! And my throat, guys, is done. That's it. My throat is calling it quits for tonight. All right, guys. So I am going to kind of wrap it up for this evening because, like I said, my throat is just done right now. Guys, next week I have Ronnie Dixon on the show, and we are doing another Q&A. But this time, I'm going to have a prosthetist right next to me answering your questions. So guys, you're going to see me on social media posting, and I love it when you guys participate on my social media posts because it just helps me spread the word on what's going on. I want you to start sending me your questions, and you can send them to my email. Questions that you want me to ask Ronnie Dixon on next week's show. Now, guys, Ronnie is no stranger to this show. He's been on this show almost as many times as I have, right? He's an amazing, wonderful prosthetist. He's an above-the-knee amputee. He's a world-class rock climber. Amazing human being, okay? So I want you guys to send in your questions because we're going to put Ronnie into the hot seat and we're going to let his throat take a hit next week. And we're going to let him do the talking. All right, guys. So that being said, as always, thank you for letting me be a part of your lives this evening. I will see you next week. Same bat time, same bat channel. Send me those questions.